Welcome everyone. Today is March 24th, 2021. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth-Hitchcock Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. You can submit your questions on Facebook Live, and we've had a few questions submitted ahead of time at wellness@svhealthcare.org. My guest today, I'm very excited about, one of my close friends and colleagues, Dr. Kevin Curtis. He's the medical director of the Connected Care Center for Telehealth at Dartmouth-Hitchcock and an associate professor of emergency medicine at the Geisel School of Medicine at Dartmouth. I'm just going to read you a few of the bullet points from the bio. I typically only read a couple of things, but he has so many things that are worth mentioning. I'm going to go through them all. He received his bachelor's degree in chemical engineering from Clarkson University, and then worked as an aerospace engineer for McDonnell Douglas Astronautics, like all of us ventured into. He earned his MD from Georgetown University School of Medicine, served for 4 years as a lieutenant commander and general medical officer in the Navy. Then got bored, I suppose, so he completed an emergency medicine residency and then received his master's in healthcare delivery science from Tuck School of Business and the Geisel School of Medicine at Dartmouth. And during his time at Dartmouth-Hitchcock, he has served as the emergency medicine research director, the assistant medical director of emergency services, and now the medical director of tele-emergency. So, Kevin, wow, you've done an amazing amount of things. It's really cool. Just let's start and tell us a little bit about where you grew up and what life was like.
Thanks, Trey. It's great to be here. I guess what all of that means is, man, I must be old, but appreciate the introduction. So I grew up in Reading, Mass, so 12 miles north of Boston, went through the public school system there, right through high school. And then after graduating from high school, lived in a whole bunch of different states and parts of the US, so some different parts of the world as part of the Navy, and then made my way back to New England now 19 years ago.
Wow. And you went into a non-medical path first, and we meet those doctors and nurses that do that, and they typically have their own reasoning. But so why were you interested in engineering at the time?
Yeah, so when I was in high school, I didn't know what I wanted to do. I think probably my favorite subject was math, and maybe second was science. So the general idea was, if you liked math and science and you were going to college, that probably meant you should major in engineering. So I did. So as you said, I went through college, got a degree in chemical engineering, and then took that job at McDonnell Douglas as an aerospace engineer. So just to put that a little context, so this is back in the mid 80s. So in the middle of the Cold War and in the middle of the Reagan Strategic Defense Initiative, so Star Wars. And not to go too deep into that, but the idea, right, was if we built an impenetrable defense, there'd be no reason for high-tech wars anymore. So I had a project that I led that was come up with a material that if you put it on the outside of stuff like missiles or something, would render them impenetrable to space-based lasers. So wow. Yeah, that was, again, something probably many people on the call have also done space-based laser work in the past. But so that was the incredibly cool project. Really enjoyed it. Very smart people I worked with. But at some point, I kind of started to question whether the initiative was really all defensive and whether that project was. And I started to think maybe I could do something a little more altruistic with my career, but still have the same amount of problem solving. And that led me to apply to medical school and start my medical career.
Wow, it's a great story. I hope you didn't just divulge classified information. But, for those of you who are listening to this podcast or viewing on Facebook Live and live in the general area of Bennington County and Southwestern Vermont Medical Center, a little trivia question that you can think about. There is another physician on our medical staff who actually, prior to going into medicine, was a physicist working on sonar and I believe radar, but I know sonar for similar reasons that Dr. Curtis. But I don't think I can say his name on air or I may get in trouble, but you can contact me privately to find out who that is. So, when you were in the military, actually, I have to tell you, I love working with colleagues, doctors and nurses who have been in the military. I learned so much from them. I know they believe in standardization because they know it leads to reliable outcomes. But tell us a little bit about your experience in the military as far as how it shaped your medical career.
Yeah, I think probably the major lessons learned are only tangentially, as you kind of alluded to, related to medicine. But to put even that into context, so when I worked for McDonnell Douglas, I decided to put almost all of my savings into stock, into McDonnell Douglas stock. And I started meds, and I was going to use that to pay for 2 or maybe 3 years of med school. And Georgetown, like many, was pretty expensive. So I started med school in the fall of '87. And some may remember what happened around October of '87, which was a market crash. So that plan changed. And, the military has an unbelievable program to pay for people to go to medical school and then to do service afterwards. And I had really no exposure to the military before, as far as essentially none of my family or friends were military, other than my dad was drafted and did a couple of years, and certainly no exposure to career military. And so joined the Navy, did a Navy, as you said, surgical internship and general medical officer. And what I really learned that was, I learned pretty quickly, was that for people in the military, it is not just a job. It is something that is part of their entire life, the whole day, the whole week, what they do, what their families do, and they are unbelievably dedicated and passionate about it, while also putting their lives on the line to protect us, of course. And it made me really think that I want to be that dedicated and passionate about medicine as they are about the military. So that it just had such a significant impact. And still, when I think about it now, it's much more on our minds maybe than it was at that point. But again, there is this unbelievable community out there doing this work that has that degree of dedication and passion. And shouldn't we all try to apply that to what we do with our lives?
Wow. I mean, I just have to say that was so eloquent. It does remind me that, most people go into medicine with a very similar, for a very similar reason, and that is to limit suffering in communities that they serve. And then you can get sort of into the weeds a bit and not see the forest from the trees. And so I can see how that military background and that dedication, that your mission is right in front of you. And that's great. So before we kind of go into telemedicine then, and the topic of our show today, what do you do outside of Dartmouth-Hitchcock with your family and for your own interests?
Yeah, I'm probably not unusual in Northern New England in that I love to be outside and I love to be active. I've been a runner for most of my adult life, and in the last couple of years, that's mostly taken the form of trail running. So I try to do that a couple times a week, and I'm always looking for a new trail to find and not infrequently get lost on, but fortunately, that's not resulted in search and rescue yet. So I do that right through the winter. Despite being an emergency medicine doc like you, I like to ride my Harley, and I like to do that on back roads and up through the Kangamangas. My whole family switched from skiing to snowboarding about 15 years ago, and none of us have looked back, so we do that again. And then still growing up in Massachusetts, I still really enjoy following all the Boston sports teams, sometimes at a pathological level, but really enjoy that as well.
Oh, that's great. No, that's super. In fact, I will say just the trails on the Dartmouth-Hitchcock property you can get lost on,
Yeah.
as I found out recently as darkness approached. But I made it back also without a search and rescue. So, well, when we talk about telemedicine, then let me before you describe your role, just how did you get into telemedicine? Was it circumstance? Did it had to do with your background? And then you can just expand on that, and we'll have a conversation in that regard.
Sure. So I got involved with telemedicine probably now 6 years ago. So at the time, among a couple other telehealth services, Dartmouth-Hitchcock had decided to launch this tele-emergency service, which we might talk more about, but just briefly is, so we have this high-tech hub at the medical center where there's a ED doc and ED nurse that is available to beam into a variety of emergency departments in the region and have live interactive help and join the local team and help in whatever way we can. So that was being launched, and I was offered the opportunity to be medical director of that service and to be one of the initial kind of core group of docs and nurses that would be providing the care. So it sounded like a very new, exciting opportunity. It also, I was excited about opportunity to potentially help. I thought it could work and could be useful, but I will, be honest, I wasn't exactly sure how it would work, right? All my prior emergency medicine was right at the bedside of people who needed my help. So I wanted to give it a try, but sometimes I'd be providing care from 300 miles away. So how's that going to work?
Right. So, all right. So let me just start by saying a little bit for our audience. There is a slight difference between telehealth and telemedicine, even though those words are used interchangeably, and that's fine. We think about telehealth as more of a monitoring aspect where you're measuring someone's blood pressure or even glucose levels from afar and then making decisions on that. But telemedicine is really doing diagnosis and treatment via usually a video type setup. And as Kevin has shown in the past, not unlike what would happen on the Jetsons and other types of sort of in the future television. It's actually happening now. So, Kevin, what does happen now? And just speak specifically to Dartmouth-Hitchcock.
Sure. So we have, as you said, that we call it Connected Care, our Center for Telehealth, and within that, and that formed in 2012, and really thinking about how do we bring care to where people are and where they need it, rather than always asking people to come to us for care. And particularly, right, we're in this rural region that it can be really hard to get to specialty care. Even in the summer, it could be a half day off for work, could be a full day off for work. You need childcare, you need transportation, never mind if it's winter. So how could we bring care to folks? And along those lines, we currently have 8 telehealth services at Dartmouth-Hitchcock. And I'll first just kind of list them and say one sentence about each, and then we can decide where to dive in a little deeper.
Okay, sounds great.
Yeah, so we have teleemergency that I described a little bit, and joining ED bedside teams to help in whatever way we can. We have tele-ICU, which is the other area that has that high-tech hub. So again, doc and a nurse sitting in this ICU hub, and we are at the bedside whenever needed at both all our adult ICU beds at the medical center, as well as 35 additional ICU beds in the region, including at SVMC. And again, helping and keeping an eye on folks just so we're all part of the same team. We have a teleneuro service, which includes telestroke. So if you come as a patient to any emergency department in that service, and you have symptoms that may be a stroke, you will, via a telehealth cart, be able to get instant access to a neurologist who will evaluate you, look at your CAT scan, decide what care is best, decide if you should get that clot-busting medication, and you get care just like if you're at a stroke specialty center. We have telepsychiatry, and then this, I'm talking about emergency, but go into an emergency department with a mental health crisis, you will have immediate access to a psychiatrist. And we know how challenging mental health resources are in the country and in the region. We also have tele-ICN, which is for neonatal care. So again, neonatal emergencies, maybe there's a preemie is born suddenly at a rural hospital. You don't have a neonatologist. Right away, you can have one via a tablet or a cart, and they can help you evaluate and treat that baby. We have telepharmacy in over 20 hospitals in the region, and that's basically reviewing and helping to do orders on pharmacy orders throughout the region. We also have outpatient virtual visits, which all of those things I've described so far are either emergency or urgency, and I need something now 24/7. Outpatient virtual visits are the term we use for, that's a scheduled appointment that many people have had now with either your primary care doctor or one of your specialty doctors, often in your own home. And then we just launched our direct-to-consumer virtual urgent care, which, for example, on your phone 24/7, if you're having cough, cold, upper respiratory infection, that kind of thing, you can see a provider via that app or phone-based service. So that's kind of a whirlwind tour of the services that we have.
And you offer those throughout the Northeast or even further, and some hospitals or some medical practices have parts of those services.
Yep.
Just to remind those in this area at SBMC, we have several services. We may be the largest subscriber to the Dartmouth-Hitchcock Connected Care Center. But for example, we have the telepharmacy, we have the stroke. If someone presents to our emergency department, they're going to get a board certified emergency physician right at the bedside. And then alongside them is going to be a board certified neurologist via telemedicine to help guide that treatment. So we're in a pandemic. How have you seen the telemedicine work? I'm certain that it has been incredibly useful in certain situations.
Yeah, so like many things, the pandemic has affected many of our services, but maybe the one that I'll call out that has had the most dramatic impact was on those scheduled outpatient visits. So prior to the pandemic, it was actually our least busy service in many ways. We were doing just 8 to 10 visits per day with a specialist or primary care doc across the region. And then there's a variety of reasons for that. Some are, it wasn't reimbursed well for payers like Medicare, wouldn't pay for visits to people's homes. There are broadband challenges that continue. For people that can't do video for one reason or another, audio or telephone wasn't paid for. There were licensing challenges. So all these things made it difficult. And then all of a sudden the pandemic hits and we went from 8 to 10 a day to peaking at 2,600 a day. So wow. Even being a former engineer, I can't tell you what percent increase that is, but it's a large number. And that was, again, across the region. Initially, a lot of those visits were telephone, and now the majority involve video. And even though as hospitals and facilities reopened, we saw a decrease in the number of visits, but we are pretty steadily at probably 800 to 1,000 a day now. So much, much more than pre-pandemic, and again, stable 800 to 1,000 a day, as opposed to continually decreasing. And we see, just to say, incredibly high levels of satisfaction, both on the patient side and on the provider side with that ongoing care.
That's great. It reminds me for the audience here, Kevin and I talk about this frequently, ascribing anything new to being the panacea for the future is bound to disappoint. But as Kevin pointed out, the telemedicine visits, these outpatient visits, stayed, and they're now stable at probably the right level, because there is a reason to go in and see your doctor in person. In fact, I'd even venture maybe a majority of the time, depending on the situation. But for other situations, and actually for other just life circumstances for certain individuals, telemedicine is very useful in that regard. I'll also point out that in the pandemic, where at SBMC was a great help, and that is in our ICU. So much new information about these patients that are sick with COVID. It's hard to keep up with it for one or two physicians, or even an entire ICU. And by working together, we were able to keep many patients at SBMC, treat them, have them stay at least in vicinity of their family. Unfortunately, their family couldn't visit because of restrictions, and then get the patient home once they were improved. And that was so helpful. And they didn't have to go through all the difficulties with travel during the pandemic in that regard. So I'm just going to hit my phone here, which is ringing, and I didn't turn it off ahead of time. But let's keep moving. We only got a few more minutes here. Do you have any comments about how you handle patients or even your colleagues that question the use of telemedicine?
Yeah, first I will say one thing that I observed, and it was certainly true of me when I first started doing telehealth, is particularly for clinicians, and I think sometimes, but less so for patients, when we first think about telehealth, we think about what it can't do. Somehow our mind goes there. It says like, and I will, just like you said, Trey, it is not a panacea, but it is what will still be an integral part now of the menu of how you would like to get your health care. It is now an option, but we tend to go, here's what it can't do. How will I get a procedure? Well, that will still be in person. How will my clinician lay hands on me? If that's necessary, that will be in person. But once we overcome that hurdle of trying both at the clinician side and at the patient side, we almost universally see, as long as the technology worked, it takes typically one experience for people to become believers. So we do spend a lot of time trying to make it as seamless, that first encounter, as possible in advance of the visit, or for either the local team, the local provider, the person, their family. But really what we found is you get to that first experience, and in general, it is, holy cow, that was much better than I thought. And we've also learned it's amazing how many different things I can effectively do by telehealth, as opposed to what I thought before I gave it a try.
Yeah, that's great. That's a really good explanation. And I'm happy to say too, I agree with you. I fortunately got exposed early, like you, many years ago, maybe as long as 10 years ago, and started looking at it heavily for our system. And my own thinking has evolved. I know something that's evolved in the past 2 years, and then really in the pandemic, was the concern that a patient may have, appropriately so, that they're losing their contact and relationship with their own physician or advanced practice provider. And that's true. Just like anything, you can go online and sort of find what you want out there, and it may just not really be appropriate for your situation. However, today, with Dartmouth-Hitchcock and with other services, you can still maintain that relationship with your chosen physician or advanced practice provider through telemedicine, and a combination of in-person and telemedicine. And I think that's where it sort of looks like right now, where it's settling out, which is fantastic. So with that, let me just say, what's it going to look like in 5 years? Do you have your crystal ball with you?
I do. What I think it will become, and is just starting to become, is telehealth and telemedicine will be so embedded in care that we will no longer call it out as something unique. We won't say, were people satisfied with their video visit, or what was the outcome of their video visit? It will just be part of how you get care. Sometimes it will be in person, sometimes it will be by telehealth, and all of it. Just like, now if you go in for an office appointment, you don't really know in advance to what degree who will be involved in the care other than your main clinician. So there might be a unit secretary or an MA or an LNA or a nurse and others, and that's all okay. It's all part of your visit. Similarly, if you're seen in an ICU or have to stay overnight, there may be telehealth involved, there may not, and it will just be healthcare. And So that's where I think we will get is that it will be such an integral part that we won't think about it as something unique. It'll just be integrated, and it'll continue to be an option for how people, is that the way you want to get your care, where you want it in that modality? And if so, we know how to do it well.
That's great. You mentioned that we tend to go to, and I do this as well, sort of the negative. What can something not do? And in telemedicine, I know you've been exposed, as have I, to really positive stories that have occurred. As we're closing up here, can you share one of those stories with our audience?
Sure. So maybe I'll go in the tele-ICN, that neonatal care. So a couple months ago, so in October, a woman presented to our regional rural hospital in active labor, only 25 weeks pregnant. Like most hospitals in the country, very highly functioning hospital, but doesn't have a neonatologist. That is, again, true of most hospitals in the country. But they did have tele-ICN. As most of us know, presenting at 25 weeks, that is high risk presenting to any hospital, and even higher if you don't have a neonatologist to help right after the baby's born. So they engaged the tele-ICN service even while the woman was in labor, before the baby is delivered. And they talked together and they said, what do we need to get ready? Let's make sure we're all on the same page. And let's think about how best to work together through this. Baby was born by an emergency C-section, and quite a bit of resuscitation occurred, and the neonatologist led them right through it. That included breathing for the baby, putting an IV in this tiny little guy, getting the baby stable, and coordinating a neonatal specialty transport to then come to the medical center. And last week, the baby was discharged from the hospital after 5 months here and is doing great. Really a great story, and a great story of collaboration between a tremendous local team, which we have all over our region, and our telehealth via our neonatology team.
Super story. And we have some similar stories right here from SVMC through that collaboration. So let me just thank everyone for joining us today. We're out of time on Medical Matters Weekly. I'd like to thank our guest, Dr. Kevin Curtis of the Connected Care Center for Telehealth at Dartmouth-Hitchcock Health. I know there is a lot of information out there on their website. If you would like to learn more, you can also check out our website at SVMC. And then you can contact us if you want to learn more about telemedicine and what's going on out there. I'd also like to thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, and Ashley Jowett from Southwestern Vermont Healthcare for making this show possible. I'm Trey Dobson. Go out and find joy, even in the face of adversity, and I'll see you next week.